Good morning, everyone. I think that we'll get started. So welcome on this beautiful, bright, sunny Minnesota morning. It's a good day to talk about housing and health equity. My name is Elena Gorder. I am the Chief Executive Officer with the Metropolitan Consortium of Community Developers, and we are a 45-member consortium of nonprofit affordable housing developers and economic development organizations in the state of Minnesota. And we are also CDFI, doing lending in the Twin Cities metropolitan area. So MCCD's roots are really in the affordable housing space. And so we came together in 1986, I believe it is. And there were 7 affordable housing groups that came together, really frustrated that there weren't sufficient public resources to build affordable housing. And so they advocated and were able to leverage 24 million, which was a lot of money back in the day, to build about 1,000 units of housing across the state. And so we continue to work collectively. Since 2012, MCCD and our members have been able to secure over 500 million in housing infrastructure bonds to build housing across the state. Today, our members that own rental housing hold about 28,000 units of housing. And last year, our homeownership members were able to build about 250 units. But this isn't enough, right? So in the state of Minnesota, only 0.4% of the total state budget goes towards housing. Think about that, just 0.4%, right? And so what that translates to is just really a lack of housing, especially for member households at 50% or below MMI. And so just to think about, to keep pace with what we need to make sure that our families are housed, we would need to build 4,500 units of housing a year. But the reality is that available resources only allow us to build roughly 550 units, right? And so I think that's why this conversation this morning is so exciting, right? And I think it's like an all hands on deck moment, right? And so the opportunity then for the community development sector and healthcare institutions to really work towards affordable housing as a way to advance health equity in the state it's timely and it's exciting. And so I'm going to turn it over to Eric Muschler, and he'll kick us off for the day.
Thank you, Elena, and thanks for co-hosting this. It is the time where all hands on deck is important. So I'm Eric Muschler, Director of the Housing Health Equity Initiative at the Greater Minnesota Housing Fund. I want to welcome and thank you for joining. We actually had 121 registered participants, so we want to keep going for the people that came on time, and hopefully we'll see more people join. So welcome. Look forward to sharing a real behind the scenes look at the trials and tribulations and joys of building successful partnerships that work across healthcare and housing from the experience of others across the country. Just a reminder of the Housing and Health Equity Initiative. We have 4 goals around cross-sector convenings where we share learnings, advance partnerships, support each other, like this convening. Developing and tracking pipeline of projects that are housing and health projects that we can research, share, and maybe replicate. Catalyzing further investment from healthcare toward upstream solutions to community health and affordable housing. And finally, convening healthcare leaders and innovators to advance investment strategies and social determinants of health and housing. And I'm excited that right now we're reviewing applications for the first ever Minnesota learning cohort of a set of professionals from the healthcare field that we're going to pull together in a learning cohort in Minnesota and talk about community development finance and affordable housing finance and the assets that healthcare can bring to that. So it's an exciting time. It's always good to know who's in the virtual room, so to speak. So I'm going to do a couple of slides. We asked registrants who registered today, and you can see we've got a good mix of sectors. 23 healthcare, 28 developers or housing organizations. We've got some funders and government, philanthropy, and finance. But a lot of you didn't want to answer because we got 21% others. So I'm not sure if you just can't decide or you're so ingrained in 2 fields of work that you just, you need to put it that way. The second question that we asked was, what's your experience partnering with healthcare institutions or community-based housing organizations? And a little over half, 55%, said that they have completed some sort of a partnership and project. Others said, 25% said they have a partnership in process. But about 45% said they either want to, but haven't tried, or just not attempted. And some have tried, and a small number without success. So we have a long way to go, but it's great to see that, about half said that they're, on the road to, or have some partnership. So I'm going to move ahead and introduce the panelists today and turn over to Robin Hackey for the first interview. We are going to record this session, and we'll post the event on the Greater Minnesota Housing Fund website after today, so you can share the resource with others who may be interested. You also might want to pull up the event page right now to see the people and their bios, because it's precious time that we have, and so I'm not going to read their bios. Just know that these are all accomplished folks, and that's really why we put the bios in, but you can read them yourself. So today we have a tale or a story in 3 parts. So first, Robin Hackey from the Center for Community Investment will interview Kevin Pogar, formerly from the University of Pittsburgh Medical Center, to hear about partnership from the hospital system perspective. CCI actually led accelerating investments in healthy communities nationally, a convening of healthcare institutions, as we are now doing in Minnesota, and gained a lot of insights and learning from the learning cohort and the process that they pursued. The second part of the story is coming from Romy Hall with NeighborWorks America. And she is over the Healthy Communities work at NeighborWorks America. And she'll talk with Kim Strand, a member of NeighborWorks, the community housing partners based in Virginia, to hear about the partnerships more from the housing and community organizations point of view. Now, NeighborWorks convened the Health Partners Investment Learning Lab, a cohort of community-based organizations exploring partnership possibilities with healthcare. And this led to part 3 of our story. In part 3, we'll have Rachel Fisher from NeighborWorks take us in a deeper dive into that new toolkit that was developed from the Learning Lab. So we will reserve time for questions at the end, but I really want to encourage people to put questions in the chat so that we can use those questions and intersperse in the conversation, or we can bring them back during the question time near the end of the session. So with that, I want to turn over the session to Robin Hackey from the Center for Community Investment for the first part of our story. Robin?
Great. Okay, thank you. Nice to be here with all of you folks in Minnesota. I've done a bunch of work in my community investment career in the state, and it's always a pleasure to work with people who are so highly collaborative. So working across sectors, I know, is nothing new for folks in Minnesota. So let me tell you a little bit about the center and the reason that we have been doing this work. We were formed about 6 years ago to change the practice of community investment so that communities would really be able to meet their priorities at scale and achieve the kinds of outcomes in terms of health and opportunity that they are really seeking. And what we knew from the very outset was that the current participants in the community investment system, noble and well-intentioned as they are an insufficient set of resources to get the job done. And so if we keep approaching the challenge of affordable housing, the challenge of climate resilience, the challenge of economic development and racial equity with the small set of tools that the field currently focuses on, then we're going to continue to have results like what you heard about, which is, people working really hard to develop housing units in the hundreds when the need is in the thousands. So when we thought about who could be partners aligned with the objectives of the community investment system, who were not currently really in the game in a big way, health institutions really popped up on the radar screen as a really important group of potential partners that had not been tapped. And the more that health people started talking in terms of social determinants of health, and the fact that housing is health, the more we felt like, wow, this is really the right time to be reaching across sector boundaries and trying to engage with a new set of players. So for about 3.5 years, we ran an initiative called Accelerating Investments for Healthy Communities. And we had 6 health systems that didn't need to be convinced to invest in affordable housing. They were already in some way doing it. And one of our kind of slogans at CCI is the future is already here, it's just not evenly distributed. And so we always look to work with the folks who are doing something new, seeking to do something new, and don't have to be kind of brought along kicking and screaming. So Kevin was at UPMC in Pittsburgh and worked with us as the team lead for that effort over the course of the initiative. He succeeded, I think, in quite grand fashion, and we loved him so much that we hired him. So this is, I think, week 3. And what I would love to do is have a dialogue with Kevin where we talk about some of the hard-won lessons, the challenges, the takeaways from the experience that we had working with a variety of different types of health institutions, because UPMC, is a large academic medical center with an insurance piece built in, and Kevin actually can talk more about that. But we also had a safety net hospital, a faith-based hospital, Kaiser Permanente, an integrated system. So many different types of health institutions played, and that was an intentional effort. Oh, and a children's hospital. That was an intentional effort to really see what are the differences across the different types of health institutions, and what can we learn by walking the journey alongside these institutions. So Kevin, let's start with the results in the partnership. What did success look like for you in this work, and maybe a little bit about what got you motivated to start?
Yeah. I think ultimately, we talked a little bit about the investments that were made, but success really started with trying to make sure that we were balancing the needs of multiple stakeholders. So that means, kind of balancing, what are the motivations for the hospital or the health system? So to Robin's point, UPMC is, an academic medical center. It also runs a bunch of community hospitals. So there's 40 hospitals, and it's the largest insurer in Western Pennsylvania. So some of what I'm talking about is going to come from the Medicaid and insurance side of this. So just want to make that clear out of the bat. But then it's really about, what are the community partners pointing out as needs, both in social services and, I think Robin said it really well, on the development side is how do we move to scale from hundreds to thousands when, we looked at the community needs assessment in Pittsburgh, the affordable housing shortage for households under, 50% area median income was somewhere around 20,000 units. And so that was something that's just kind of a, blinking red light on the dashboard, and it seems like something we can really jump into. And I think that really is where things start to take root. And then it's also about trying to think about, well, how do we play in the system in a way where we're doing a value add? If we're going to be the 800-pound gorilla in this room, how do we come in ears first and try to think about the neighborhoods that are going to be affected and the systems, and how we can kind of bring a whole scope of things to the table, not just dollars, right? And so that's kind of the win-win-win that we were looking for. And for the healthcare folks on the phone, there's a lot of thinking always that goes into the AAA with healthcare, which is, in essence, aiming for better care, improved health outcomes at lower cost. But in this world, we're really trying to put together, social impact AAA, if you will, which is really more equitable communities, better health outcomes, and getting kind of, assets out the door at kind of no, low, or moderate rates of return, just to kind of be able to kind of build those and things up in scale. So, for us, the partnership and motivation started with, a decade of programs really geared at keeping seniors in place, living in the community, providing other permanent supportive housing programs through clinical initiatives and partnerships with social service agencies. And the biggest lesson we were learning right around the time AIHC started was that, there's just not enough doors to open. And we know from a healthcare utilization and outcomes perspective that the housing makes that big of a difference, especially in those priority populations where people are going to the hospital unnecessarily because they're not able to get preventative care. And affordable housing is really the anchor of that. So that was, kind of the motivation is we don't need to, buy a building and put only the people we need to serve in it, but we can figure out a way to decompress the system. And also as a, our kind of presence as an insurer means there are neighborhoods in Pittsburgh where we're headquartered that, 40% of all residents had a UPMC insurance card, if not more. So that kind of scale too, where really community health starts to, benefit a whole host of people who are living there.
Yeah, and one of the things that's interesting to point out in terms of the motivations, and the hospitals and health systems that participated had a range of things at the top of their agenda. Some of them were more motivated by an economic return. What was surprising to us was actually the number of them that did not have that at the top of their agenda. What we found was that for a lot of the systems, particularly the faith-based systems, the mission of standing with the poor or fostering wellness rather than providing health care, was enough to get them started on this. The thing that was most surprising to us was the number of systems who were doing something that meant that doing a community effort like investing in affordable housing was really key to their institutional self-interest. And that might mean that they were doing a campus expansion, they were looking for a merger approval. There was something where the neighborhood, the mayor, the city council was really a factor. And when you look at the health systems that have done the most outstanding work in this area, many of them got started because they were doing some kind of thing where it was really important what the community and the elected officials thought of them. And so this is a way of advancing institutional self-interest beyond narrowly conceived economic return. So, Kevin, can you talk a little bit about the partnerships that you put together, because this is a team sport and no health system can do it alone?
Yeah, and I mean, I think that there's kind of three different examples that are worth touching on. Kind of from, and this is looking at only in the investment piece. The thing I want to point out here is that there were some other things that we were doing to form kind of service relationships and those kind of things. But if there's not an investment component to your housing strategy or any of the other ways that you're approaching social determinants of health from the healthcare perspective, you're just not going to be able to do enough. You're basically making referrals to community resources, kind of overcrowded emergency room, to kind of use an analogy. So the first thing we were able to do through accelerating investments for healthy communities was make a low interest loan to help spark a capital loan or capital pool with a local CDFI. So the CDFI has been around for 30 years or so. That's a community development finance institution, in case anybody's unfamiliar, kind of a mission-oriented bank. So they were really looking to start their journey into real affordable housing. They had done some lending to housing folks, but not really, deed restricted or in a tax credit space or those kind of things. So that was a place where they were interested in going right around the same time that we were interested in making these investments. So they had been working already to kind of, get a little bit of interest from some foundations and some bank capital. But at the end of the day, it was when UPMC came forward with a $3 million loan that we were able to also get a grant from the Kresge Foundation through accelerating investments that was critical. And so we kind of launched this fund that had $7.5 million in and out of the gate. And subsequently, Bridgeway has gone out and added more money to that. So it's a $9 million capital pool now that will revolve for the next 15 years. So, in terms of, how that was working, it also created this bridge for us to developers and, community development corporations that were doing the work. Some of whom had been longstanding partners of the health system through ongoing community tax credit programs, where we help to kind of build capacity in some of these organizations to put together real estate plans. And that was, that's been really exciting. And what that did more than anything was give some validity, because there's a lot of talk from healthcare institutions around housing as, a component of healthcare. But at the end of the day, if you're not putting the dollar out, then people are always going to be looking at you skeptically. So when we finally made the first investment, that really gave us some more credibility, and that helped lead us into some other coalition things for lobbying for some statewide distributions of both American Rescue Plan dollars and an increase to the state housing trust fund. So we also joined into a campaign as a result of all this to kind of increase the grant dollars that were going out from the state housing finance agency. And so that was successful, adding $20 million more a year statewide. But through that experience, what was interesting is we kept really flexible terms with that initial thing. So it funded everything from preservation to new construction and LIHTC, and we really made it as flexible as possible. But what rose to the top through that process was that there was a real need to focus on the preservation of affordable units. So I mentioned before, the city is looking at a 20,000 unit shortage. Well, if we're building a couple hundred every year and losing 1,000, that kind of equation just didn't really work. And so that led us, down a path of, what would it look like to put together a comprehensive preservation strategy? And at the end of the day, Bridgeway Capital, our former CDF partner, was like, that's a different form of lending. We're not really willing to step into that space. And so we had to basically form from the ground up with a ton of leaders from, the largest Action Housing, who's the largest nonprofit development here, folks at the city and county. We formed this preservation working group and spent 18 months figuring out, okay, well, what do we need to look for? How much money do we need to get started? And how do we make this all kind of come together? And it's not inked yet or anything like that, but very excited on the progress it's made there, and kind of expecting really good things in the near future. And the last one was actually a donation from the hospital system itself of land. So this was in the form of a 99-year lease. It's a parcel. So UPMC is also in this time period doing 3 major capital projects, one of which is the flagship hospital. And so the strategic plan had been done in our core urban campus, and there was a couple of parcels that, weren't in there. So it's, going to be 10, 20 years before anything happens with that site. And we knew through all these conversations that one of our partners, who's a senior housing provider, was looking to form a senior low-income LGBTQ friendly community. And they had put in all of the work, hundreds of people in focus groups, all these kind of things to really narrow in on what that looks like, how to do the model, how to do the financing, but they just couldn't get a parcel to put together a low-income housing tax credit application. And so because they were a partner of ours for a long time on the healthcare front, it made it a really easy transaction to say, this is somebody we can trust. They have a great reputation for asset management. And also, we're rolling out this affirming care provider or affirming provider certification for this campus. Wouldn't it be great to also, offer living arrangements for the members of the LGBTQ community that we're trying to serve?
So I think, it's worth emphasizing from what Kevin said, a couple of points about who the partners are, both internally and externally, and what the assets are. So it was interesting that the government relations folks got involved, because when healthcare shows up and advocates for housing, the unexpected messenger really is a very powerful ally. And I think that was a very pleasant surprise. I think the real estate guy, who ended up being one of the champions of this whole project, he doesn't have the grant dollars or the investment dollars that the community benefits folks or the investment folks had at their disposal. But, land costs money. If you donate land or you lease land, you don't need the money quite as much. So the fact that there was a parcel identified, which happened in several of the participating health systems, is a really important thing to remember. Who knows what land the system has? Who could be brought to the table to say, hey, we don't really need this. Telehealth and employees working remotely have changed the configuration of the real estate that we need. What could we do with that land other than sell it to the highest bidder? So I think what you hear in Kevin's story is a really important feature of the cross-departmental work that has to go on in the health system, which turns out not to be standard operating procedure for most places every day. And then on the flip side, the external partner side, I think the work really took off and accelerated both in terms of speed and effectiveness when the dialogue went directly to developers, to the CDFIs, to the community folks who could say very clearly what the needs were, the elected officials, the folks who were in the different local government agencies, even the state HFA got involved. So, multiple partners involved in that. So, Kevin, given all of the success and the multiple plates spinning, could you talk a little bit about some of the challenges, both internally and externally? What was hard?
Yeah, I mean, internally, it just boils down to we had no framework for doing this. It was one of those, who makes the call on, doing this kind of new activity, which is, making mission investments. And so, I'd say it took us 18 months to kind of fully socialize things with, clinical stakeholders, population health stakeholders, and really make sure we had buy-in with, a lot of the different departments, primarily in the health plan, because at the end of the day, the source of these dollars were Medicaid reserves. So we spent a lot of time just providing education of what the different links between housing and healthcare were. We leaned on success from different programs where we could see the real outcome value to individual patients over a long period of time, which was really useful in this. And then at the end of the day, we ended up just having to tailor messaging and have multiple rounds of dialogue with leadership to figure out, how do we get this done? How do we shape this into a way that it makes sense? And so just a lot of back and forth with the different ways in which we could invest, and just getting to the point where, community stakeholders were frustrated because it's like, well, we're going to do something. And they're like, well, what are going to be the terms? And I was like, well, what would you want the money for? And so there was a lot of this ambiguous dialogue going on in that period too. And so there was this constant state of refinement of, what set of deals can we kind of be pulling in here? And, that was the concern of leadership, is how do we know we're not just making an investment in a property? We don't want to be an owner or a holder or directly invested in anything. We want an intermediary. And then also, how do we make sure that all the money doesn't go just to one developer or one project? And so that was, again, where working with the CDFI really helped, but it was a lot of give and take in getting to that process.
Okay. In a minute, I'm going to turn this over to Romy Hall, who is one of our favorite health and housers from a different perspective. But before I do that, let me just ask Kevin, what advice, given your experience, do you give to people who are embarking on the journey?
Yeah, for health systems, it's really just work with the professionals. There are practitioners in your community, and you need to just get them into the conversation early. Align your goals, define those shared priorities, and really trust their judgment and how to move those things forward. And for the developers, it's really important to understand that this is an investment. This is not free money. This is dollars that could have went to the next clinical program, the next hospital expansion, whatever it might be. So it's really important just to keep in mind that you're not asking for a grant or free money. It's something that's really tangible, and it's going to have some kind of return, whether that's financial or community benefit. It's important to make that case around the value of the investment, however that is. The other thing I would say is kind of around effort is, for health systems, it's more important to not do one deal with one partner. Think about how to immediately build the infrastructure to do something that moves a batch of projects or brings together a host of community partners, because you might be surprised just how much change that can generate, and how much benefit that will bring back and impact it will add to the investment that you make. And then just kind of reiterating for developers is, if the health system hasn't done this before, and even if they have, it might be really difficult to figure out who the decision maker is. So be patient, hang in there, people will champion this. And at the end of the day, money follows good ideas, and this is a great idea. So it's just a matter of staying patient and making that case in a way to, get these things over the finish line, even if it, even if it takes kind of the marathon time, not the sprint time.
Great, thank you very much. So I'm going to turn it to Romy, who had the the vision and the wherewithal to take the lessons that we learned from working with health systems and stand them on their head and translate them for NeighborWorks developers who have now been building partnerships with health institutions. Romy?
Thanks so much, Robin. Hello, good morning, everyone. As Robin shared, I'm Romy Hall, and I'm the Director of Healthy Homes and Communities at NeighborWorks America. If you are not aware about who NeighborWorks America is, we are a congressionally chartered organization with nearly 248 member organizations that are in every state, the District of Columbia and Puerto Rico. In Minnesota alone, there's 7 network organizations. We support our network with grant funding, peer exchange, peer learning, which you're going to hear more about today, technical assistance and evaluation tools to advance their health and housing, to advance their affordable housing and community development work. And then particularly about 10 years ago, NeighborWorks, we really recognized the deep ties between community development, affordable housing, and health. And so we've really continued to advance and support the network around funding and peer learning and opportunities and toolkits and resources, all that you're going to learn a little bit more today around our health partnership investment strategy. And in nearly a decade, we've just really started collecting more robust data, but nearly 70% of the network of the NeighborWorks network are doing some kind of activities around the intersection of health, housing, and community development. So I just think it's really amazing to see this evolution of this this intersection between these fields, between our sector and health, and just really setting the table to create these kind of partnership opportunities with healthcare. But I'm here today to actually interview Kim Strom, who is Vice President of Strategic Operations from Community Housing Partners that's located in Christiansburg, Virginia. And Kim and another colleague of hers participated in our Health Partnership Investment Learning Lab. We hosted this Learning Lab last year, and as Robin shared, and knowing about Center for Community Investment and all of their work, we kept on hearing our network was building these health partnerships. They were looking for opportunities to secure investment capital. And so this kind of question came up, and Robin and her team at the Center for Community Investment partnered with us to explore what does it take for affordable housing and community developers to build health partnerships that can utilize capital to address inequities and achieve community priorities. And what was really sort of important as we learned through this process is that it's not just about securing capital, that a healthcare institution is more than a bank. It can do so much more. It's an anchor institution in communities. And so what ways can we partner together to truly address inequities and root causes that create poor outcomes and create a better opportunity to create more thriving communities? And so with that, I'm going to interview and have Kim really share. And I think what's really different about this, we wanted to have somebody who's just far enough in to kind of share with you about their experience, about what it takes to move health partnership investment. So it didn't feel like, oh, this has been done. It's not done. It's like still process and creating. And so with that, I'm going to just start with Kim. Tell us a little bit about who you are, who's Community Housing Partners, and if you can also talk about why was CHP, why were you in particular interested in this health partnership investment work?
Thank you. Thank you, Romy. Yeah, and I just want to preface this or kind of reiterate what Romy said is that we don't have this all figured out. It is a journey and we are on the journey. But knowing that over half of the attendees on this call have either completed or in the process of a health partnership, I just want to make sure that you don't think of us as the expert because we're just figuring it out. But CHP, Community Housing Partners, we are a 47-year-old affordable housing organization. Our primary line of business is affordable housing development, multifamily development. We have developed over 8,000 units of rental housing in a 6-state footprint. We also maintain ownership and management of our portfolio. We currently have about, I think, 6,100 units that we own and manage. And we provide service enrichment to all of our residents as well through our CHP Resident Services Program. We also have a homeownership division. We also have what we call Energy Solutions Division, which is actually the roots of our organization. We started with the Federal Weatherization Assistance Program, doing energy retrofit work, and we're currently still the largest provider of weatherization in the state of Virginia. But health, I'll bring it back to health. So we started talking about health because it's in our mission to create homes and communities that are healthy, sustainable, and affordable. But the reason I spoke about the Energy Solutions Division is because we, for many, many years, thought about health through that lens, through our home retrofit work. You know, we were thinking about it in terms of indoor air quality, in terms of safety, and healthy homes primarily. And so, you know, that was good. That wasn't a bad thing necessarily. But then in 2015, thanks to NeighborWorks, we were at a NeighborWorks symposium and we were introduced to the concept of the social determinants of health. And for us, it was really, you know, an aha moment. We were like, wait a second, we're impacting health in so many, in every aspect of what we do as a community development organization. And so that was really quite a turning point for us. And we started talking about it really internally, talking about health, and did a lot of sort of awareness for our leadership around what the social determinants of health are and how we're impacting it. And then in 2017, it became one of our 4 core strategic plan goals, which was to improve the health outcomes of our residents and clients. And once it hit the strategic plan, it really had some teeth in there. And now it is definitely, you know, part of our vernacular and part of, you know, who we are as an organization. And I can get into the specifics on that a little bit more. I presume you'll ask me some questions about that, Romy.
Yeah. Well, I think one of the things that I think was interested as you were doing this journey of health, in that time period, you also had a health institution in Virginia, Bon Secours Mercy, that also was doing that journey and made available capital. So you all were able to secure. So if you could talk a little bit about that, but now how that experience, now a few years later, now you're at this place with like, how can we be more strategic about entering in these partnerships and finding ways to address inequity together to improve health outcomes? So I'm wondering what that journey is and how sometimes luck happens, but now it's sort of a different body of work. So if you can share that a little bit more.
Absolutely. I mean, luck is a good word for it. We were in the right place at the right time. We did have, I think our COO at the time knew somebody higher up at Bon Secours hospital system. They had, I mean, this was 10 years ago, maybe. They were pretty progressive and already understood the impacts of safe, quality, affordable housing on health. And they had some impact investment commitments. And because they knew us and we had a good reputation of building quality, affordable housing, they came to us and said, we want to provide you low interest loans for your development work. And so, you know, at the time we were like, yeah, great, a funding stream. We were not thinking, admittedly, we were not thinking about that health and housing partnership at the time. It was just another funding source for us, which was, you know, really, really great. Now that I think about it, how they were just ahead of their time, I think, or ahead of, not everybody, but they were ahead of the game in terms of the partnerships we're talking about today. So that happened, and they've been increasing it. We have a $4 million loan from them now at a 1% interest rate, which is really, really helpful. And we use it for as capital for our development projects. And we just have to do some reporting to them as to the production that we've completed within their footprint, their focus areas in Virginia. But I will say, you know, once we really started thinking about the community level health and housing partnership, that was when I think, Robin, somebody spoke to this, like we were really thinking about it in terms of programmatic partnerships. We were also fortunate enough to have a couple of hospitals in Baltimore approach us to create a health suite in one of our redevelopment projects in the city of Baltimore. And that was a huge partnership. We focus on health and wellness activities for the residents in that community where there was a significant need. I mentioned our resident services programming. We do a lot of, you know, partnerships there as well. But again, that was on the programmatic side. And we weren't necessarily intentionally seeking investment until we entered the NeighborWorks Health Partner Investment Learning Lab. When did that start? Was that last year or the year before?
Yeah.
And that's when we were like, okay, we need to be thinking more than just the programmatic support. We need to be thinking about what messaging and what motivators should we be thinking about in terms of getting capital investment. So Romy, I'm happy to jump into talking about our actual Learning Lab project, or
Yeah,
did you
that'd be
have another?
great. Yeah,
Okay.
no, let's unpack that a little bit. Yeah.
Right. So part of the Learning Lab, which it was great, kudos to everybody involved. We chose a geographic region. We chose the city of Roanoke, Virginia. It's actually right down the road, about 30 minutes down the road from our headquarters. And that was where I feel like we really started to understand what it takes to get a health partner investment. We had kind of honed in on the biggest health provider in that area, Carillion Clinic. And we took us a while to get to the right person. And, finally we got to the right person, but she didn't know us at all, which was interesting because they're 30 minutes away, but she didn't know us. And it was just, we weren't getting traction. So through the Learning Lab, we learned about, shared priorities of other community stakeholders. And so we started meeting with other community stakeholders. And it really just started, it was like this networking, but it really just started connecting the dots across the community. We became familiar, or we became aware of a targeted revitalization neighborhood where they had a parcel of land. And we thought that might be a good way for us to get our foot in the door in the city. And then it turns out that there's another healthcare institute, New Horizons Healthcare, that was looking at that same parcel as well. And now we are connected with them and might do a joint venture development deal on that parcel. So it was never our intention to, hopefully it'll have a great happy ending, but it also was not how we planned it, right? I don't think it ever is. And so we went in with one intention, and after literally like 18 months of talking to the right people, or not talking to the right people, I guess, we finally, have some traction. And actually this morning I was at a meeting with somebody from Carillion, the larger group, told her about this partnership. And she was like, oh wait, we want in. She was like, let us know, because it's an exciting opportunity. And so maybe we hadn't presented the right motivators until we kind of went around and made some of our own partnerships. So.
That's great. Kim, could you share, I think it's really helpful, and I know you have a list, like who are all the people you talk to?
Yeah, I did write that down because I was thinking about the challenges of this work, and it is trying to find the right person. Definitely, well, so it's different at different hospitals. So our partnerships in Baltimore, we're working directly with MDs, with medical providers who are Johns Hopkins, and they're doing research-based work. So they were really focused on that particular neighborhood and population. Inova Health, we're working with them up in Northern Virginia. Government and Community Relations Director, I think Robin mentioned that as well. I wrote that unexpected messengers is definitely something we've run into. Community and Health, Chief Community Health and Health Equity Senior Vice President, that's also at Inova. So that's health equity, I think, is something that we're seeing more and more, in titles within healthcare. Planning and Community Development Vice President was one. At Bon Secours, it was their Director of Investments and Director of Community Health. Those are the two people we work with there on the loan that I mentioned earlier. So it really just runs the gamut. And I do think that we've actually had luck. I didn't write this down, but we've had luck going through our legal counsel, who will talk to their legal counsel, and then they'll be able to say, you probably want to talk to, that's just been a helpful channel for us. Those lawyers know everybody, so.
They do. Can you, I think it's really helpful to understand like the mapping and identifying who's in the health system and the network and how you leverage your legal counsel as well as theirs. Can you talk about some of the other steps that you took to get ready to really robustly engage in a health partnership investment strategy?
Sure. I think this is probably just, specific to CHP, maybe not unique to CHP, but in my position, strategic operations, I focus on a lot of strategic initiatives. And so I sort of owned this health and housing world. And so, I was doing my own research or whatever and reporting out to our like executive team, but they were just like, great job, Kim, keep up the good work. And so with the Health Partner Investment Learning Lab, I actually recruited, and kudos to NeighborWorks for, I think that there was a requirement that that an executive level person participate. And so Lance Sutherland, he's our CFO. I said, hey, Lance, let's do this. And he was totally on board. He did not come in kicking and screaming, I promise. But that was a huge, huge win for us internally, because immediately Lance recognized the importance of community engagement. That is not something that we had historically talked about. We were very much like, we're getting this money, we're building this building, and then we do the community engagement to help support our residents. This proactive community engagement, we are not a place-based organization. We cover 6 states. And so that was a huge gap that I think I kind of had an inkling that was a gap, and Lance really it rose to it bubbled up to the top for him, and he really started to understand the importance of community engagement, which in his role as CFO is critically important, because it's not something that you see immediate return on investment on, like that community engagement piece. And he even said to our CEO, he said, I think we need to build capacity in this community engagement space. And he made the argument on my behalf that that might not result in immediate financial return, but it will help us be more competitive in RFPs. It'll help us create partnerships that will ultimately help us with our business, really. And so that was huge. That was huge for us, is to involve our CFO.
That's great. And I'm wondering, Kim, if you can share also a little bit more about, I'm wondering if you can just share a little bit more about one of the things that I think is really interesting is that you all are looking at community engagement, starting to explore. You're in multiple geographies. And one of the things I'm just thinking about that Kevin talked about was not coming to healthcare to with one one deal, but thinking of a batch of projects. And so one of the things that might be a little different about your organization, you have a whole set of projects that you're looking at in a community. And so I think about the way of how the community engagement and the scale of need could sort of match the batch or a set of pipeline projects. Can you talk more about the sort of transformation that you all went on of going from we need funding from one development to thinking about, oh, actually, we have a pipeline of projects in this area. We're starting to understand what's happening in this community better and differently, and the strong need for affordable housing. And also you did some work around understanding the history of the community. And so I'm just wondering what that process was to go from one to more of transformation to multiple.
Right. And that was certainly a huge shift in thinking for us. We are definitely opportunity driven and, on a project level. And so, and we're still going through that transition. We have not switched over to that, but that was a huge lesson learned from the Learning Lab, which was that pipeline, thinking about our work from as building a pipeline of potential projects with health partners at the helm, or not at the helm, us at the helm, but with health partners. And I think in Roanoke, which is where we focused our Learning Lab work, we were new to that. We haven't broken ground on anything yet. We are new to that city, and there's a lot of opportunities through. A lot of doors or a lot of opportunities present themselves because their rents have increased. And so now they'll have more competitive LIHTC. We'll be more competitive in the LIHTC applications there. So that was the first, hey, we should start looking at this city. And then the second, when we did the HPIL work, it was okay, we started meeting with the city. We met with the CDFI there. We met with just a lot of different school systems, a lot of different folks that were focused on this one revitalization area. And the realization that we could provide a huge piece of the puzzle in terms of that community revitalization, I think is what is leading us to develop a pipeline there, and not just multifamily, single family as well. We just got CDBG funding from the city for single family development there as well. So, I mean, a lot of it is just being at the table. And I think that, and being at the table, not to talk about a specific project, but being at the table to talk about the community's needs. And that's been transformational for us. And I'm excited about where it's going to take us.
So Kim, I just have a final question, and then we're going to turn it over to Rachel in a minute. What would be some like 3 pieces of advice that you'd have for folks as they're starting this journey around health partnership investment?
3, that's a lot, Romy.
I know you got it, or just one big one. You tell us.
Well, patience is one. I think that's a common thread that I heard on this call so far. But patience is one, that it takes time and that it is a journey. I think knowing that the first person you talk to at a hospital, like Inova Health in Northern Virginia, I made an ask, got a no, and then I kind of wrote them off. I'm like, well, they're not interested. And then I talked to somebody else from Inova and they were very much interested. And so if you get a no, don't close the door. That just means you haven't talked to the right person yet. And then this is just to reiterate the other one that I thought, well, okay, I've got, look, I'm going with 4, Romy. Overachiever. I think shared priorities. That's like the huge buzzword, not buzzword, but aha word that we took from the Learning Lab, is recognizing the community's shared priorities and where we fit into that. And it doesn't mean you have to share every single one of their priorities, but there's definitely inevitably overlap. And then the 4th one is just to reiterate the involvement of our CFO. That was huge for us, and getting his buy-in and his recognition of the importance of this work.
Well, thank you so much, Kim, for sharing about your journey on health partnership investment. And I'm excited to continue to support community housing partners as you move forward. So we're going to turn to the 3rd act of today's conversation. And I'm so happy to introduce my colleague, Rachel Fisher, who is a senior manager with our community initiatives team. Rachel's going to share about a toolkit resource that NeighborWorks and the Center for Community Investment co-developed together. And this toolkit directly came from this Learning Lab. And so all of the lessons and the nuances, what Kim has shared, we really try to represent that in the toolkit. And so with that, I'm going to hand it over to Rachel to introduce us to this toolkit and the tool.
Great. Thanks, Romy. And thanks, Kim, for that great conversation. Hi, everybody. I'm Rachel Fisher. As Romy said, I work at NeighborWorks on our community initiatives team, and worked with Romy and Robin and the team at the Center for Community Investment to implement that health partner investment learning lab last year. And from our perspective at NeighborWorks, our work through the learning lab really had 2 main goals. We were looking to support a cohort of our network organizations like Kim and CHP to help them understand and advance their own health partner investment initiatives and working to achieve community equity and priorities. But we also really wanted to use that opportunity to build a body of work and learning that NeighborWorks can use for our own goals and to support the rest of our network of local organizations, as well as the wider field to help them as they pursue these partnerships as well. So based on the experiences of those 6 organizations, we really learned that more than anything, doing this work takes time, and there needs to be a significant investment in that readiness factor that is critical to embarking on this journey. As Kim shared, there's a lot of different components that come into that for these opportunities to be fruitful, like bringing in your leadership, focusing on community, and working towards that readiness framework. We distilled all of our learnings from all of these different projects, and building on the knowledge and expertise really that Robin and her team at the Center for Community Investment have been building to bring them together into this toolkit really with the goal of helping community development organizations and housing developers get the knowledge and internal supports in place to pursue partnerships with health institutions, or to be ready when those opportunities may come to them in the way that Kim talked about with Bon Secours. So I'd like to share some highlights and some learnings from the toolkit and our work leading up to it. I'm going to put some of the toolkit up on the screen. I think we are sharing in the chat as well the link to it where you can access it on your own. But I'd also really encourage you to dig into it, because it is quite long and there's much, much more than I'm able to share with you here today. But this toolkit, from silos to collaborations or building a health partner investment strategy, really pulls together all of the lessons that you've heard about today and is designed to highlight the steps needed for community development organizations to shift their practice. Because as we've heard throughout both of our conversations today, this type of work really does require shifts for both CDCs and housing developers, but also for healthcare institutions, because this is a way of moving capital in a new and innovative way that really has the power and the capacity to make an impact in addressing racial inequities and other really deeply rooted systemic issues to work towards more equitable communities and ultimately towards those health outcomes. So this toolkit really is designed and is about supporting developers in helping to secure an investment, but it's really at its core about getting your team ready to start down this journey. And we think that it will help you understand how to partner with the health sector, but also see a lot of benefits in ways that it could set you up to better impact your communities in other ways as well. So I'm showing here briefly just our table of contents, just to show the breadth of content and the tools that you'll find in this toolkit. There are a lot of frameworks and tools to understand the healthcare landscape and learn to leverage the work and resources and internal strengths in ways that community development and housing can be leveraged to address systemic inequities, which is why this toolkit really starts by shifting our focus, looking at the root causes of communities and circumstances and their needs. And when based on this project, when we focus on looking at root causes, we're really focusing on what that means for the approach and the role of community development or a healthcare leader. What you'll see here is our kind of vision that came out of this work for ways that partnerships between health institutions and development organizations shift the way that they work to increase their impact. Under what we're calling an institutional mindset on the left, you can see where priorities currently align in more traditional focus areas, maybe housing affordability and economic opportunity for developers and medical care for health institutions. But really, in moving towards that transformational mindset, these partnerships redirect their focus and shift their priorities to jointly work, moving towards those root causes or social determinants of health. So this toolkit recognizes that all of your organizations are coming to this from different places, but our goals are really towards moving this body of work to get to that transformational place in as many areas as possible. And so the frameworks and tools presented throughout here and in a really robust appendix, which I'll touch on as well, are really designed to help guide that shift. The first part of which is really understanding the connections between these different industries. So we start off by exploring health institutions and their intersecting interests with community investment. And really, while the toolkit kicks off and starts by helping developers learn who's who in the health system, because we recognize that these may be different industries that you're not as familiar with, we also and also explores the motivations of health systems, which we heard Robin and Kevin talk a little bit about earlier. We're also really looking to expand the understanding of opportunities for different ways for investment to achieve maximum impact. We saw that a lot of our organizations and developers came to this project, this work, looking for deals, like Kim said, looking for that investment. But it really would be a missed opportunity not to explore the different ways that healthcare can invest and partner, and to also think about the best type and most appropriate type of support that not only can to meet your development needs, but also really to benefit the community and their priorities in the way that maximizes addressing those needs. And I know on this call, along with community development organizations, we also have some folks from health institutions and partners. And while this resource is geared more towards developers, I also encourage you to take a look at this section just to understand some of the different ways that developers are approaching this work, but also other ways that health institutions have invested in housing. And in thinking about how we can best drive impact and thinking about starting to partner, we heard from Kim and we saw it with all of our organizations, the difference in strong health investment strategies when they are rooted in community. So throughout this chapter and also throughout the appendix, we give a lot of tools for engaging with community, particularly residents and local partners, really with all of this, with the goal of trying to make sure that all of this effort and these dollars are directed towards what's actually going to make the most impact, not looking at just new development, but also trying to seek deep community change as well. Kevin talked about how important it is to build upon projects and working with a group of community partners. And those projects in your pipeline will be much more meaningful and well received when they reflect direct input and participation of the neighborhood, and when they are working towards an intentional and community generated approach, which really helps strengthen your case for why this investment is a good idea for them and for the community. And all of this, talking about different approaches and who the right actors are and thinking about community, again, all comes down to this root idea of readiness. And based on our experiences with our colleagues that participated, and also in partnership with Success Measures, who's a group within NeighborWorks with expertise specifically in evaluation and learning, we lifted up these 3 key areas that organizations should focus in on when they're thinking about where to embark on this work. Thinking about orientation and mindset, thinking about organizational culture, and also thinking about organizational capacity. And so we've dug into each of these areas to identify some of the really key concepts with each of these areas for your teams to elevate, because we recognize this is not black and white work. This is not somewhere where you can make a checklist and say, we've done these things, but it really takes time for your team to dig into these different areas and find the spaces where you need to enhance your work to be more transformational. So taking the time to look at the ways in which your organization centers racial equity, centers internal and cross-divisional collaboration, identifying clear priorities, identifying if you have the capacity or where there are places to take on this work. And so this tool and these frameworks are here for your team to really guide your conversations and dig in and discover where in these areas you already might thrive and be really strong, which can help activate this work for you. And also identify the areas that may present challenges that can be really bolstered before you start down this road and they come up later on. And just to pull all of this together, we finish by thinking about what it takes to connect with health institutions, including assessing a health institution and their internal frames. Kim already has highlighted for us the full breadth of people she worked with, and Robin and Kevin really highlighted where your champions might not be exactly where you expect. But thinking about all of these pieces and then pulling it together with some examples of how they all fit together so you can get a glimpse of what this might look like for your organization. And then, like I said, we have also included through this work a really robust appendix with tools and worksheets for your team to spend time getting clarity around community engagement, clarifying your team roles, and developing your pitch deck, and all of the different kind of technical pieces that go into getting ready to start forming these partnerships. So we're really excited to be able to share this resource and our learnings from a lot of time spent on this work. And what was really important to us was helping folks come to this work with a different mindset. There's a lot of tools and frameworks here, but I think the most important thing when you're starting on this journey, if you're interested in pursuing this path, your team needs to be ready to be adaptive and start to think about work a little differently than you may have done. So I'm not saying this toolkit is a direct roadmap from you start here and you'll end up getting an investment, but really helps you put the pieces in place to start your own journey towards partnership that will allow you to leverage your expertise and resources in health and housing, ultimately to affect deep change in the communities that you serve. So we've shared out the link to the toolkit. I encourage you to take a look and see how it might help your organization move this work forward. And I thank you for letting me share a little bit about what we learned and what you can find here, and would welcome any questions or comments about the toolkit.
I also would open up the floor for questions to the other panelists, the interviewers, the interviewees. It is an opportunity to sort of have some opportunity to ask questions to these folks who have a ton of experience. I mean, I'm excited because the work that we're doing in Minnesota is building on some of the work that's been done here. And I'm very excited to bring it to Minnesota. And it's a great opportunity to take advantage of some of these learnings. So open again to questions for anyone. I know sometimes it's hard on Zoom to stand up or be the first one to stand up. One of the things that I thought was interesting in the pre-survey that I'll mention, so basically 55% of you said you've completed or in the process of completing a partnership or project connecting health and housing. And I'm curious if those partnerships are direct partnerships with healthcare institutions, or more of what I'm familiar with is sort of permanent supportive housing work that goes on. We have a very strong permanent supportive housing field of work in Minnesota, but sometimes that's with a nonprofit that provides health services. So I'm curious about what that looks like. And I want to note that on our website, there is a submit a story button that we're looking to always collect sort of these examples of partnership. So I welcome you to do that as well. So do we have any questions out there? Who's going to be bold and ask a question? All right. You can open up at any time. But I have a couple of follow-ups. So this is more to Robin and Kevin. I'm wondering how the finance folks viewed affordable housing in the beginning as a investment versus once they got connected with it and understood it more, what that looked like.
Kevin, you want to start?
Sure. I mean, in the case we would always make is, these dollars could go into any number of things, but at the end of the day, these investments have, some kind of collateral behind them, and ultimately we're mission motivated to make these investments because the demand is so high, right? So it's a really secure asset class. It's just, you can't get a big return on it. And that's why we need to be investing in it. And so that was the case we made, was that we know we need to do more to address social determinants. If you can provide housing as that bedrock, it really kind of expands over those other pieces. And so it was just getting them comfortable with the fact that, by demand and by nature, these are really safe. We're not, investing in a business. It's, an asset that is critically needed.
Interestingly, we had a lot of finance folks from the different health systems that were involved in the program. One of the guys who was chief financial officer at Nationwide Children's Hospital got so motivated by the investments in affordable housing that he ended up using $1.5 million or making $1.5 million commitment to a loss reserve for a fund that was then a total of $15 million. And it was an unfunded guarantee, so he didn't have to write a check. He was convinced, and I think he will be proven right, that they're never going to have that loss reserve called on because the underwriting was quality underwriting. And so they were able, using just the balance sheet and commitment of the hospital, to unlock $15 million from other investors, philanthropic and financial. So that was one extreme. And he then became CEO of the hospital because the board was so impressed by the leadership that he showed, frankly, at a national level, doing this work that he went from CFO to CEO and has since expanded the work. So that's yay. On the other side, we had a hospital that was involved in a couple of projects with very well-known, well-respected developers, where the financial people said, look, we recognize that it's a loan. We're going to put it on our balance sheet as a grant. And if it gets repaid, yay, but we don't believe you. And we'll see it when we see it. Our experience has been over time that when people begin to understand that actually this is not a risky asset class, the finance people tend to become very big advocates, but that takes time.
Thank you. Scarlett, I think your hand is up. Do you want to ask the question?
I do. Thank you for allowing me to ask. So just in hearing about how, developers are partnering with, major healthcare providers. One thing that I just wanted to comment on is I am based out of Grand Rapids, Minnesota. And if nobody has a clue where that is, we are in the middle of nowhere. It is, to us here, it's a bigger community, but we have a large amount of these bedroom communities of 200, 300, 500 people communities. And when we look at the need for housing, we are in dire straits. Our average age of housing stock is over 70 years old, 50 to 70 years old on average. And when we look at, major employers, if you have a good job in this area, in the greater Arrowhead region of Minnesota, if you're making $25 an hour, you're kind of in that perceived upper crust. Okay. So it's very different from, metro jobs. If you're working as a nurse up here, you can anticipate $40 an hour versus the metro where you're probably making double that. So when we're taking a look and trying to develop affordable housing in this area, it is very, very difficult because one, nobody really understands what affordable is. Nobody wants to touch it because we have all these perceptions that it's slum housing or people in active addiction or this or that. And we also lack resources, we lack capacity, and we lack the understanding. So, and a lot of these hospitals have gone to major chains like Essentia or Fairview. So trying to partner in with them when you're a nonprofit and you're going to have to partner with a co-developer from the metro to build your capacity, we're at a real challenge here. And then trying to present this to communities as this is a major asset. We know from tons of research, go on Google for 10 minutes and you can find that there is a major correlation between health and housing. But how do we sell that? We recently went into a community. We had a letter of support from Essentia Health in that community, and they shot us down because it wasn't market rate. It wasn't housing for locums. It was for the working class, the forgotten third of America, the working poor. So that's something that is interesting to me. And when Kevin, you were talking about, kind of like a land trust model, how do we in northern Minnesota make that work when we're kind of, fighting an uphill battle? Plus, as light tech developers, we are competing with the rest of the state. So it's just my 2 cents. I know that's kind of all over the place, but just thoughts if you could, please. Thank you.
Happy to start. Robin also would look to you for a conversation about capital absorption and use of that tool. Greater Minnesota Housing Fund is working in Greater Minnesota, has over a 25-year history of doing so, and obviously don't have all the solutions, but are constantly working to assemble capital so that we can reach communities like you're talking about. Most recently, there's a model of workforce housing that we've replicated about 5 times now, where we're not using tax credits, but rather because we are, and without the tax credits, the cost is significantly less, but it does require some local resource, right? So it's not using federal tax credits or through the state tax credits, but it could be a donated piece of land. Maybe it's from a healthcare institution, maybe it's from a business, maybe the city has land. But those sort of identifications are what can catalyze resources around a particular project and could make that go forward. So I'm looking to, I'm happy to sort of connect with you after this and work with you on that. So.
Yeah, and I would just say very briefly that one of the most powerful strategies that we've seen in changing mindsets is to figure out who in a particular healthcare system is actually making the income that you're talking about for the residents of the affordable housing that you need, and make it clear to folks that we're talking about their own people. And for many health systems that we've seen, that's a real eye opener, because they do have a mental image of what we're talking about. And then when they realize what they're paying their own folks, it's like, oh, that's not them, it's us.
Yeah, and just to echo that, I mean, that was one of the things when we were making the case, we had a table that we're like, here are 4 income bands and the kind of person that works here who might fall into that. But beyond that, it also kind of, led us, at UPMC thinking more about how do we put these things out in a way that supports naturally occurring affordable housing too, which, we've seen in Pennsylvania as well. That's a huge part of it where, incomes are lower in the rural parts of the state, but that also it doesn't mean housing demand's less, but there are those kind of things. So one of the other things we advocated for at a state policy level was a whole home repair program, which is going to be funded to the tune of 125 million, which was also critical in all these other efforts as well.
And I just wanted to maybe to weave in, Terry, you asked a question earlier about the storytelling and leading with community issues. And part of what I heard in your question, Scarlett, was, or your comments was around how do you frame up and pitch and present a really compelling story to healthcare. And Kim and Lance and their work at Community Housing Partners, they really developed a dynamic pitch as part of the Health Partnership investment. And I was wondering, Kim, if you could share some of the elements of what you all put in your pitch that really kind of illuminated the kind of work and community need together.
Yeah, I mean, I think the pitch was developed through what I mentioned earlier about the shared priorities, is that once we understood what the community was looking for, and so, in terms of the messaging, we relied a lot on, oh gosh, I'm drawing a blank, on the healthcare's, what's the assessment? Community needs assessment, is that what it's called? Community needs assessment that the healthcare group had done, as well as their implementation plan that resulted from that. And we also relied a lot on some of the cities or the counties housing needs assessment reports. And so we didn't have to reinvent the wheel. We thought, this research into this community has already been done, and here's where we can tie in. And then the other thing is we went a little bit deeper. And for example, in Roanoke, we knew that they were focusing on youth and the health of the youth in that particular neighborhood. There had been a dental program thing at a local school there. And so our pitch was, about the work that we do. We have after school programming. We do a lot with the youth within our communities. And so we tailored our pitch to really talk about that. And so I do think that could be, depending on the needs of the community, I do think it can be something that you might not think of until you understand what the community is interested in hearing.
And that was the difficult part, is because going through the community, when not only had like a community needs assessment done, which identified a massive need for housing, but also looking at the city's comprehensive plan, where they too also defined a massive need for housing, and looking at, the major employer, the healthcare system that was there, saying we need all ranges of housing. We had that there. We gave the data, we gave incomes, we gave everything. But ultimately, a lot of what we face is, these smaller communities are looking at, okay, we want to focus on community appearance versus.
Did we lose her?
I don't know. Did we get feedback, or yeah, I think we might have lost her.
Oh, sorry. Can you hear me?
Yep.
So,
Yep.
so like I was saying, we looked at, the community needs, all of this. Basically, each, the hospital, the city in their comprehensive plan, they outlined, a definitive need for all ranges of housing stock, affordable, market rate, senior, workforce, the whole nine. But it comes down to the preference over community appearance versus community need. And stigmas, stereotypes. We've heard, what are we going to do about those people? We don't want, quote, those people moving in, and it's really that, small town NIMBYism, and we see it in larger cities too. So we have explored that. We put out income levels, and where you have maybe 90% of the population that is making anywhere from $15 to $28 an hour, that would very much well qualify, for workforce housing or affordable housing. They would much rather focus on that remaining 10% of locums who are making, 30, 40, 50 plus an hour, which is what we're really struggling with.
I recently did a little bit of analysis on the workforce shortages in Greater Minnesota, and actually wrote an article that's in the newsletter that's on our website. But I have to say, you can't identify a healthcare institution that isn't struggling that as a top priority for them right now, because they're so short, and they're worried about being able to maintain a workforce, attract and retain workforce. And so it is a very good time to engage on just this topic of workforce housing. The other thing that I've seen done, and this happened in Thief River Falls, DigiKey, the business leadership of the community on the basis of economic competitiveness, workforce, have often stepped up in communities and really helped prioritize housing and the collection of resources and collective action around it. So that's another thought on how you might engage in it. Otter Tail County is a good example of creating a whole goal around affordable housing, engaging the business community around them. So another example, and again, I'm happy to sort of share those specific examples when needed. Other questions?
There was one from Terry and one from Patty.
Okay, I think, so Terry's was related to community input, actually community-driven input, and when, I think this is right, Terry, and you can correct me if I'm wrong, but when is the engagement of community happening? And whose responsibility is it? And at what point in the process of development is it really necessary to have that? That could be answered by a number of folks. So who wants to jump in?
I can start. We are, again, just learning in this area, but we have found, so for example, many times our development projects start with a response to an RFP, right? And so when we're putting together that project team to create an RFP, a proposal in response to an RFP, we are now bringing in a group that is focusing on community engagement. And it's a third-party group. Their name is Brick and Story, based out of DC, and they're amazing. And so they come in and they help us do some community outreach even before we have solidified a project. And so again, though, we're sort of falling back into our old ways of having it be project focused. And what I'd like to do is work with this group to do some of that community outreach work before we even have a project identified. And so, and then honestly, we have a graphic of a project timeline. That community engagement point, it's a bar graph that goes across the entire project timeline. And then when we lease up, that's when our resident services are doing that community engagement work. And so it really never stops. It just looks different once you've got the project underway.
Kevin, Patty asked a question about, you mentioned the medical reserve fund. Could you, Medicaid reserve fund, could you talk a little bit about that? And this is going to be the last question, just because I don't want to hold people over. But thanks for the questions. So Kevin, can you answer that, and then I'll wrap up?
Yes, I was actually just typing a response to you. So there's a little bit in the chat. And so there is a paper out from Community Catalyst that folks could look into that kind of outlines this specifically and gets really in depth with it. I couldn't find the link at the moment. It appears to be down. But like I said in the chat, in essence, this boils down to every Department of Insurance at every state has a minimum reserve requirement for the insurance companies operating in those states. And so if you're at the minimum, you're kind of, it's kind of the warning light. If you're double the minimum, you're okay. And then once you get above, kind of 4 times the minimum, somewhere in that range, the companies are able to invest the dollars over that line. So that it's not going to be every insurance company that's going to have the ability to use these investable reserves, but UPMC and specifically our Medicaid company had a very healthy balance sheet, and that's where we were able to kind of go and look for these dollars. And we kind of made the case of these dollars can be invested in bonds or other stable assets. They're yielding 4, 5, 6% somewhere, or we can discount that rate and put it to work in the local community and do all these other things, leverage all these other dollars, and really kind of get the reputational and stakeholder things. And another thing there is you're seeing trends as states issue their RFPs and procurements for their Medicaid contracts, that this is becoming more and more of an area that secretaries issuing those want to see. And so there's also some motivations there around being competitive in the marketplace that also we kind of tied into. So just something else to think about. It's not just hospitals, payers are a major part of this equation.
A couple of different leverage points that are not at a healthcare institution, but at a regulatory institution that you do have available. So good points. So I want to just thank everyone, Robin, Kevin, Kim, Romy, Rachel, Elena, for hosting this with us and sharing your wisdom with our crowd. And looking forward, we're going to be releasing the Minnesota Healthcare Learning Cohort in the end of February. So we have great applications and a mix of people from healthcare that we hope over the next year we'll be able to really work with and hopefully identify opportunities where partnership is really called for. And so we look forward to doing that. So thank you everyone for your participation today, and we will end 2 minutes late. Sorry. Take care.
Thanks for coming, everyone.
Thank you so much.